Welcome to the Deep Dive, where we cut through the complexity and extract the knowledge you need.
Glad to be here.
Today, we're tackling a topic that, well, at some point, touches every single one of us. Serious illness. Because in those moments, when life takes an unexpected turn, the focus often shifts. It's not just about prolonging life.
No, it becomes about profoundly enhancing its quality, making every moment count, really.
Ensuring dignity and comfort, not just medical intervention.
Exactly. And that focus on person-centered care. That's precisely what we're going to unpack today.
So our deep dive today explores this compelling 2025 study. It's from BMC Palliative Care by Shufton and colleagues.
A really interesting piece of research.
It gives this fascinating look into how 8 different European countries manage palliative care specifically for adult cancer patients.
Right.
Our mission is pretty clear. We want to distill the most vital insights on statutory coverage, what's officially covered by government health systems and the practical access people have to these crucial services.
We'll see where care truly shines, where it maybe falters.
And importantly, why. All through this unique vignette approach they used, which kind of brings real-world scenarios to life.
And understanding how these, quite diverse health systems approach such a sensitive area, it can offer some profound insights, I think, into the healthcare challenges, opportunities, really no matter where you are listening from.
Yeah, it really highlights the human element within these big, complex systems.
Definitely.
So let's start with a foundational question then. What is palliative care, truly? Because let's be honest, for many people, it's still kind of shrouded in misconceptions.
Oh, absolutely. Often mistaken as purely end-of-life care, which is just not the case.
Right.
That's such a critical distinction. Palliative care aims to maintain and crucially improve quality of life. It offers person-centered options for people with serious advanced illnesses and, importantly, their families too.
So it's holistic support.
Completely. Managing pain, other symptoms, coordinating care between different services, and addressing the patient's physical needs, functional needs, psychological, social, even spiritual needs.
And it starts much earlier than people think.
Yes. It really should begin around the time of diagnosis of a serious illness, not just in the final days or weeks.
And it definitely extends beyond just the medical therapies, doesn't it? I mean, the World Health Organization has a really broad definition.
They certainly do.
Yeah.
The WHO sees palliative cancer care encompassing not just treatments aimed at prolonging life, like chemo, but also supportive care. That's looking after the physical, emotional, even spiritual side of the illness. And here's one that's so vital for families: respite care.
Ah, yes, giving carers that much-needed break.
Exactly. From the constant strain, often through, short-term facilities or specific services.
But the real core of it, I think, what really sets palliative care apart, it's this profound emphasis on emotional and spiritual support, right? Aligning with the patient's own goals, their values.
That's the heart of it. It's about dignifying the individual, ensuring their wishes are heard, their comfort is prioritized, not just focusing on the disease itself.
And this whole topic, it's becoming increasingly urgent globally.
It really is. Cancer, as we know, is the second leading cause of death worldwide. Yeah. But it's not just cancer, actually.
Right.
The need for palliative care is skyrocketing, partly because of shifts in how diseases impact populations, more people living longer with chronic illnesses. And then there are the broader demographic changes, like our aging global population. So it's not a niche concern anymore. It's becoming a growing, almost universal imperative.
Okay, so let's unpack how they actually studied something so complex, so nuanced, across 8 different countries. They use this clever vignette approach. Can you explain that a bit for those maybe not familiar with research methods?
Sure. It's essentially a short but quite detailed description of a hypothetical patient scenario. It's designed to simulate a real-world situation, and then you gather insights from experts based on that standardized case.
Yeah.
It's a smart way to make comparisons more consistent across different settings.
Makes sense. So what was the patient scenario in the study?
They presented the experts with a very specific patient, a 60-year-old man with stage IV non-small cell lung cancer.
Okay, quite advanced.
Yes, and suffering from moderate to severe pain, breathlessness, and also acute moderate depression. So a complex picture. This detailed profile that the experts in each country really envision a concrete care plan for this shared scenario.
And the ideal care plan they envisioned based on that vignette, it sounds incredibly comprehensive.
It really was. It included not just the oncology teams, but specialist palliative care teams, ideally working, seamlessly together.
Right.
The medical side involved treatments like chemotherapy, of course, but crucially also detailed symptom management, various opioids, benzodiazepines for anxiety, that sort of thing.
Really focusing on pain and anxiety relief.
Exactly. And even seemingly basic but vital additions like laxatives and enemas. Things critical for managing side effects and, frankly, maintaining dignity.
And beyond the purely medical.
Well, the plan also included psychological assessment and support, antidepressants, and, this is vital, advanced care planning conversations.
Ah, those crucial discussions about future wishes.
Absolutely. Like preferred place of death, what interventions they'd want or not want down the line. And it didn't stop there.
Wow.
The blueprint even accounted for services for the carers, psychological support for them, respite care, bereavement support later on, plus essential non-medical support.
Like what?
Things like social and financial assessments, maybe help getting home equipment, even financial advice. It really painted a picture of truly holistic wraparound care.
Okay, so which countries were involved in this to get that diverse perspective?
They included 8 European countries: Bulgaria, Estonia, France, Lithuania, the Netherlands, Portugal, Sweden, and England. Yes, chosen specifically to represent different health system features and also geographical spread across Europe.
And who filled out the surveys in each country?
It was a mix. Health services researchers, actual practitioners, sometimes government officials, or even expert teams. The key was they all had direct, on-the-ground knowledge of how care actually works in their country.
Got it. So with this ideal plan as the benchmark, the next logical step was, well, what actually gets paid for? Where do the systems maybe start to show limitations?
Precisely. What services are generally covered by the state? And where do the cracks, or maybe the variations, start to appear?
So what did they find overall?
Well, the sort of good news is that the core services, things like oncology, team care, chemotherapy, common drugs like opioids and benzodiazepines, those are generally covered by the statutory health systems in these countries.
Okay, so there's a foundation.
Yes, a foundational level of support for those critical medical needs seems to be there.
But, and there's always a but, isn't there? Where does it get more complicated?
Right. Here's where it gets really telling. The variations in patient cost sharing, even for things you might not expect.
Like?
Well, okay, hospital stays might have general deductibles in places like the Netherlands, France, or Sweden. That's not specific to palliative care. But the study found striking differences even in, say, the cost of laxatives and enemas.
Which are vital for comfort, as you said.
Absolutely vital. Yet in Portugal, patients had to pay fully out of pocket for these. No reported financial protection. The Netherlands applied mandatory deductibles.
Wow. It highlights how coverage isn't always total coverage, is it?
Not at all. And these seemingly small gaps can add up to become a significant burden, especially for patients already facing immense challenges.
And what about the non-medical support? Things like social assessments, home equipment, financial advice?
Yeah, the variations were even more dramatic, showed up in nearly every country surveyed.
Really? How so?
Well, England uses means testing for benefits. In the Netherlands, sometimes patients have to reapply for prolonged care after just 6 months, which creates uncertainty.
That sounds stressful.
It does. And in France, social care wasn't always well covered, often forcing families to rely on voluntary health insurance or even charities like cancer associations.
So it points to a real fragmentation, like the health and social systems aren't always joined up.
Exactly. A fragmented approach where the social safety nets often don't integrate seamlessly with the healthcare side.
What about the specialist palliative care teams themselves? How are they organized and funded?
Again, quite differently. In Estonia, for instance, the service isn't systematically defined or even funded by the main health insurance fund. It leads to this sort of piecemeal, fee-for-service approach for crucial people, like psychologists and social workers.
So you might get some bits covered, but not others.
Potentially, yes. England, on the other hand, relies heavily on its well-established third-sector hospice movement for some aspects. That's a different model altogether.
And I found this astounding. The coverage for advanced care planning. Those really crucial conversations about patient wishes.
The variation there is quite stark, isn't it?
Huh. It really is. Fully covered and routine in Bulgaria, England, the Netherlands, Portugal.
It's great.
But then essentially non-existent or just not routine in Estonia and Sweden. And for France and Lithuania, the study couldn't even get information on the coverage.
That's a significant gap. These conversations are so central to patient-centered care, to ensuring dignity. It's a vital oversight if they're not happening or not supported.
And what about support for the carers, the families?
Another mixed bag, really. Psychological support, respite care, bereavement support. They might be covered through various channels: statutory health insurance, social care systems, local government, sometimes external organizations.
But often only partially.
Often only partially covered, yeah, with some cost sharing required from families in countries like Bulgaria, France, and the Netherlands. So again, the emotional and financial burden often still falls heavily back onto the family unit.
So, okay, we've talked about coverage, what's supposed to be paid for. But even if something is theoretically covered, can people actually get it? Let's pivot to the access challenge. What real-world barriers did the study find?
This is where the practical realities really bite, and one of the most pervasive problems identified across almost all the countries looked at.
Except the Netherlands, I think.
Exactly, except the Netherlands, was geographical access, travel times.
Right. Care facilities clustered in big cities.
Pretty much. Concentrated in larger cities, forcing patients from rural or even suburban areas to travel, often long distances. And that creates extra barriers, doesn't it? Especially for lower-income patients or those who are already physically frail.
It's a clear geographical disparity, an equity issue.
Absolutely.
And then there are the more systemic hurdles, waiting times, staffing.
Oh, yes. Waiting times were flagged as a significant barrier in England and Estonia. They're missing oncology service targets, which just adds immense stress for patients.
And Estonia, you mentioned earlier, only has 3 specialist palliative care centers in the whole country.
That's right, 3 centers, which immediately raises questions about how equitable access can possibly be across the nation.
And other countries have workforce issues?
Yes, Lithuania was highlighted for having a severe lack of physicians in palliative care. The study suggested this was down to ambiguous regulations and maybe inadequate financing, basically making it less attractive for doctors to specialize.
So a systemic issue deterring people from the field.
Seems like it. And Sweden, too, has specialist palliative care hospital wards in only about half of its regions, plus a pretty limited number of hospices nationwide. These are real, tangible structural barriers limiting who gets care.
So beyond the logistics getting there, finding a bed, finding a doctor, what about the less tangible barriers? This raises an important question. What else gets in the way?
Well, the study highlighted several layers here. There are organizational barriers, practical things like limited pharmacy opening hours in Bulgaria and England, maybe making it hard to get pain meds when you need them. Or personnel shortages, specifically for psychological professionals, mentioned in France and Lithuania.
And then there's the societal dimension.
A really powerful one. Stigmas and shame. Identified in England, Estonia, Portugal, and Sweden. Shame around accessing certain drugs, particularly opioids, which carry historical baggage.
Right, the addiction fears.
Exactly. But also stigma around accessing psychological therapies.
Right.
Imagine needing help for depression related to your illness but feeling ashamed to seek it.
That's heartbreaking. And on top of that, knowledge gaps within the healthcare system itself.
Yes, this was quite concerning. Experts in Estonia and Sweden reported that healthcare professionals themselves sometimes lack experience or even fear prescribing certain medications, particularly opioids.
So the prescribers are hesitant.
Apparently so, which then directly contributes to access problems for patients who desperately need that pain relief. It's a really deep-seated issue.
Wow.
And then there are cross-sectoral problems. That lack of systematic cooperation between health and social systems we touched on earlier, seen in Estonia, or just low numbers of social workers available, like in England and Sweden. That hinders access to that vital non-medical support.
If the systems aren't talking to each other, the patient falls through the cracks.
That's often the result.
Yeah.
And perhaps most significantly, a barrier identified in 5 of the 8 countries was directly related to the practitioner-patient relationship itself.
How so? What kind of issues?
Well, concerns ranged from physicians maybe not being skilled enough or perhaps comfortable enough to thoroughly explain palliative care and address patient fears that came up in Bulgaria and France.
Okay.
In Estonia, there was a perception that specialist care teams sometimes don't prioritize incurable patients, which is, well, the opposite of what you'd hope.
Yeah.
There were also reports of poorer quality of care for certain minority groups in England. And in Sweden, existing prejudices among both patients and healthcare staff about what palliative care actually is and whether it's even useful.
So deep-seated attitudes getting in the way. It makes you think, doesn't it? When you're already fighting for your life, the idea of also having to fight the system or fight stigma just to get basic comfort care, it adds another layer of suffering that just shouldn't be there.
It really shouldn't. It points to a deeper cultural and educational challenge within these healthcare systems. It's not just about building more facilities, it's about changing attitudes and ensuring compassion understanding is embedded.
So, okay, putting this all together, what does it mean for the real world? The study clearly found that the actual care people get often differs, sometimes quite significantly, from that ideal vignette they started with.
Absolutely. For instance, in Lithuania, it's often general physicians and nurses who spearhead palliative care, not necessarily specialist teams like in the ideal plan.
Right.
And in Bulgaria, specific services like using benzodiazepines for breathlessness apparently aren't consistently part of standard palliative care planning, even if a patient might desperately need them. It just highlights that gap between the blueprint and the reality on the ground.
But amidst these challenges, were there any signs of innovative solutions, ways systems are trying to adapt?
Yes, definitely. France and England offered compelling examples of trying to overcome those geographic barriers we talked about. They use mobile palliative care teams.
Ah, so bringing the care to the patient.
Exactly, bringing specialized care directly to patients in their homes or local communities, especially those who might struggle with travel. It's a really vital adaptation, I think.
That makes a lot of sense. So reflecting on this whole deep dive, what's the big takeaway?
For me, it really underscores just how critical communication about palliative care is. Communication among practitioners, between doctors and patients, with family members, with carers. It's absolutely paramount.
To overcome that skepticism and stigma you mentioned.
Yes, and to facilitate full, transparent explanations of what palliative care offers, what its benefits are. And that shift we're seeing from focusing purely on clinical services towards needing integrated social services too, that just highlights the profound need for effective communication across all the parties involved.
Making sure everyone's on the same page, basically.
Exactly. Ensuring patients receive truly comprehensive, coordinated support.
So, looking ahead then.
Well, the need for palliative care is only going to grow, as we discussed. So health ministries, insurers, policymakers, they're going to be increasingly focused on guaranteeing not just coverage on paper, but real, equitable access.
And this study gives them some pointers.
It offers vital insights, definitely, into the existing frameworks, the strengths, but also the very real, very human challenges within them. I think the focus moving forward really needs to be on standardizing pathways where it makes sense, supporting the co-design of services with patients and families, promoting much clearer communication between the providers and the payers, ensuring the workforce is sustainable.
Tackling those staffing issues.
Yes, fostering better care coordination across health and social care, and just maintaining transparency throughout the system.
It's a lot to tackle.
It is.
This whole deep dive, it really shows us how complex, but also how deeply human palliative care is. It goes so far beyond just medical treatment, doesn't it? Into that crucial social, emotional, spiritual support.
Absolutely.
It's clearly a field in constant evolution, grappling with everything from financial coverage, nuts and bolts, to these profound societal stigmas. It really makes you ask, how can we ensure that palliative care becomes truly patient-centered? Not just seen as care for the dying, but as comprehensive support for living with serious illness from diagnosis onwards.
It's a critical question.
And maybe for you listening, what role do you play in advocating for or even just understanding these crucial conversations for a future where quality of life truly remains central even when facing the toughest diagnoses?